was in the intervening time, NHS England decided to send him to Newcastle and back. So we are in fact very lucky to have William back here this afternoon. A couple of us were having a bit of a minor panic about whether he would make it here on time. Good news for you all is has a clinical background, so unlike some of us, will probably use the right terminology in the right way. And has had a variety of jobs across the NHS and academia before taking on this role. So I'm going to hand you over to William to talk about the new models of care and the learning. Good luck. Here's the pressy button thing that I broke earlier.
Good afternoon. It genuinely is a pleasure to be here. I've spent the last 48 hours travelling around England, trying to get to various places and back. But one of the reasons why I did that was because I really wanted to come here today. And I wanted to come and talk to you, not just because you asked, though that does help. And I don't think I've ever been designated as a keynote speaker before. Usually I'm the substitute for the person who was the keynote speaker who couldn't turn up at the last minute. But I wanted to come because I wanted to talk to you about some of the work we've been doing, but also some of my reflections on the work you've been doing, because this is probably, and it sounds trite when you say things like this, but this is probably some of the most exciting stuff I've done in the last 10 years of my career. Beverly talks about me being a nurse. I still am a nurse. I think it's probably best I don't go near any patients anymore. There's quite a lot of patients who probably say it was good that I didn't go near them before as well. But when I think about why I left being a nurse and why I came to be a manager, I was somebody who really felt passionately about delivering better care for the people we serve. And I got increasingly frustrated with managers who found reasons and problems why we shouldn't do a better job. I then became a manager and quickly became very frustrated with clinicians who didn't want to do a better job as well, which is a slightly different discussion. But I think it was really to think about, well, you know, you're a Vanguard, you're one of these 50 sites across the country doing these really exciting things, and that means a lot. But I suppose at a boardroom level, that means a lot. You can put that in the HSJ, you can make a big thing about it, but actually, what does that mean to you on the front line, delivering care every day, facing the real pressures that we're under, the increasing waves and waves of people who need our care, the reduced amounts of capacity that you have in the system to see the people you want, and increasing pressures to deliver more and more, time and time again, to higher and higher levels of standard. And I think I wanted to talk a little bit about that today. So I've got a set of slides, which I'll probably talk a little bit about. But I think I'm going to talk a bit more about kind of my experience and why I think what you're doing is really, really special. So to start with, I think it's worth sort of saying that the whole programme for the new care models came out of the 5-year forward view. The 5-year forward view identified 3 big gaps that we face over the coming years. And anybody who's worked anywhere in the front line will know this. Firstly, that we face a significant challenge in terms of care and quality. That the more people we see, the challenge of continually getting the quality to be at the high level we want it to be, whilst also seeing people within shorter and shorter turnaround times. And the expectations of those people growing over year on year on year means that as things grow and as services have increasing demand, how do we start to meet those needs of those people, but also do it in a way that delivers quality? Secondly, we face a really fairly significant gap, which is that if we think things are tough now, wait until the next wave comes. So the people who have not huge health problems right now, but in 5 to 10 years will do, because they're waiting for their problems to occur. We're not preventing ill health enough, and we're not doing enough to stop people getting sick in the first place. So we become more and more treatment focused and less prevention focused. We save this big challenge around preventing ill health in the first place. And then the third challenge, and it's inescapable, is there's not a lot of money in the system, and there's a lot more to do. And if you look at most Western healthcare usage, it grows at about 3.5% a year. So against no additional funding, that creates a fairly sizable gap, somewhere in the region of about £20 billion. So it's a fairly big challenge, and we've got to start to think about how we address those needs. And one of the ways was through developing new care models. So different ways of working, rather than just saying that we're going to do the things we've always done before, because if we go harder, we'll get faster and better and be more efficient. We know that doesn't work. We've got to do something different. So the programme was set up to try and be different. There have been lots of national change programmes, And some of them have delivered really impressive outcomes. Some of them have delivered really good things at an individual place or system level. What they haven't done is then be adopted and adapted across the country. So one of the challenges is you can do something brilliant locally, but how do you do something across a wider footprint? How do you get others to take it on board and not say, well, that's not going to work here or that wasn't invented here? And so we felt that there was a different need to look at how you approach this programme. So firstly, putting clinicians absolutely at the heart of this change. You know, as a clinician myself, I know that you can't make any change happen if the clinicians aren't bought into it and don't believe in it, and it isn't going to make the right difference for the people they serve. So we've got to work with clinicians to make change happen. Secondly, we have to involve people who use our services in a completely different way. It's not enough to go out, identify something we want to change, run a consultation that says, do you agree with what we're saying, and then decide we're going to do it whatever, irrespective of what it says. We have to look at a different way of working with people to deliver the services they want. Thirdly, we know that you've got to do these things from the bottom up. You've got to build it from the people locally. You can't say at the centre, do this, adopt this, because we know from history that if we do that, some people will do it, some people will say they've done it and won't actually do it, and some people just won't do it at all. So how do we get something that works for you locally, but then can be replicated across the country and adopted and adapted for delivery? So that's where we come in how do we offer you the national support that means we get some of the silly things that get in the way at a national level from you doing what you want to do and create perverse incentives. So there's 50 sites across the country doing Vanguard work, of which you're one of them. What's really interesting and I find really exciting about the care home Vanguards is the approach you're taking is very, very different to anything I've seen before. The approach to really concentrating and focusing on not the organisations and the buildings and the systems, but actually on the people we're serving. So having this really clear idea that we're here to make things better for that person and to help people receive their care closer to home and actually have a better independent living if that's what they want. And then across the 6 care home Vanguards, you're working really well together. So it's not just that you're doing something really interesting here, but you're actually starting to see amazing sharing and learning between the different Vanguard sites, where you're adopting and adapting things. So last week, I was talking to both Dudley and Tower Hamlets, who are Vanguards in the MCP cohort, who want to adopt elements of your complex care premium and say, how could they do that in their area? Because they've seen what you're doing, and rather than saying that wouldn't work for us and, oh, that's not right, they're asking questions about how could we take that and apply that to our local context. So the work you're doing here is being replicated in pockets around the country. So how do we do that and blossom and grow from that as well? But it's also, the other programme I lead as well as the care home programme is the Pioneers programme. And the Pioneers were 25 places across the country who are still doing integration between health and social care. So starting to work about joining up the system. And some of the learning that we have from these sites is being felt in the work we're doing here. So the work they've done around information governance, the work around workforce is now being brought into the New Care Models programme to help learn so that we don't have to go as long and as far as they did to deliver some of the changes. And then there's things we're doing across our team to start to look at how do we offer you in different areas ways of delivering support at a national level which will respond to your needs and help you. So I suppose to think about, well, what do I think is really different about some of the new care models? Well, firstly is the fact that they start with the population health as a real idea. So when I come into the offices and I come to your care homes and I come to your practices and I look up on your walls, I see stuff about what your locality's doing and the idea that you've thought about what you need to do that's different in Stevenage from the Upper Lee Valley, but also what could be the same between those two places, and how do we really focus on what that population needs, its unique challenges and problems, and how we support those areas to do consistent things, but actually also to allow for the variation that differs in both population, services, rurality, etc. The other thing I think is really important is to talk about the primacy of primary care in this, so the importance of enhanced primary care to all of these care models. So it's all good and well having amazing hospitals that deliver amazing care, but if we don't have brilliant primary care that underpins that, that's the cornerstone of how we deliver great care. It's the thing we should be really proud of in this country, which is our general practice in primary care are a model that others in the world look at and go, can we do that? How could that be something we learn from? And absolutely at the heart of the care home model is the enhanced primary care support from your practices and your community teams to engage with those care homes and support them and wrap care around them. The other thing I'd say that's really interesting about Eaton of Hearts and how you've worked is that when I came here for the very first time, which was probably about 8 months ago, nobody talked about health and social care. People talked about care, and they talked about people. They didn't talk about patients. They talk about what do we need to do for our local residents. And it's really interesting. I was quite affected by it. I've never been anywhere when you walk through the door, everyone, if you cut them in half, were on message. But at the same time, it was clear nobody had gone round to them and gone, here's the message. There was no briefing sheets hanging around that you could see out the corner that said, whatever you do, don't mention the war. But everybody spoke with one voice. And I go to all these things, and you go to leadership school, and you go to management school, and you go to all these things, and everyone talks about, we've got to have a shared vision. Shared vision is absolutely essential. And it is. But when you actually try to work out what does that really mean, well, it helps if you all speak the same language. It helps if you actually all seek to understand that this is about the people we serve and about building from the blocks of what you do locally and then doing that aggregated across an area. And that's really different here. And it might feel tough for you guys, and it might feel like you're not very far on at times, but trust me, the stuff you've done in that area is really different, really, really different. It's one of the reasons why the team keep getting badgered. Will you come along and do a talk? Will you come and talk to people? Because what you're doing is different and is important. So what's in this care model? Why are we doing it? Well, firstly, we're doing it because we want to provide joined-up services for people who no longer really are able to live independently. So if you were to look at our population, we know that it's ageing. We know that in the next few years there'll be more retired people than there were working age people. And we know that those people often don't have the opportunity to live independently for as long as they would want to. They face a range of challenges in terms of accessing services, getting joined up care, and getting people to come around and work towards their needs rather than organisational boundaries. So this care model is all about delivering that person-centred integrated care, which again sounds like a load of management rubbish when I say it out loud, but actually if I start to come to East and North Herts and actually talk to people about what that really means, it's really clear what that means. It's about how you talk to each other, how you work together, about the fact that you're doing what's in the best interest of that person, rather than talking about this is what my organisation does or this is where my boundary ends. And this is about the people. So this is about giving people that opportunity to live as normal a life as possible. It is about letting people get the best clinical outcomes and letting them decide what those outcomes are, but also to feel part of that community. So to really feel, what is it here? We're not just sticking old people in a building and then they're never seen again. They're actually part of the community and part of the, the vibrancy of the local area. So what appears to make that difference for care home residents? Well, we think there's 7 things. We think, firstly, it really is about having enhanced primary care support for those care home residents. It's about having really good access, wrapping around a care home, so that there's proactive care for some of the most complex and sickest people in our society who deserve our support. Secondly, it's about then also having something that when you do need that specialist support, you can access it simply and easily, and that you can get the expert advice when you need it, so that we're not in a position that we identify somebody has a problem and then they end up going into hospital anyway because there's no one to come and meet those needs. We know it's about something I think you've done really well locally, which is about reablement and rehabilitation, so keeping people at home as long as they can with the services wrapped around them to support them, so that the care home becomes the place you go to when you really need it, rather than somewhere you go because there's no alternative. We think it's about end-of-life care and dementia care. 20 years ago, I looked after people on care of the elderly wards. If I were now to walk into a care home, so a residential care home, let alone a nursing home, the people I see in those residential care homes are the people I used to nurse 20 years ago on elderly care wards. What we've done over the last 20 years is shift the acuity. So people who used to be in hospital are now living in the community, in care homes, and people who are in care homes are now living at home. And that brings real challenges to everybody, because it isn't just about saying this is about a 10-minute appointment with a GP and, if you just send them along if there's a problem. You'll know as primary care practitioners how hard it is sometimes to manage some of the complexities, but also you've really got to build the time in to go and see somebody and really give them the time they deserve. It isn't a 5-minute appointment. It isn't a short consultation on the phone. But we also know it's about this issue that if you go into care home now, it's because you're either in the last years of life or you have fairly significant cognitive impairment, often dementia. So 75% of our care home residents now have dementia. And again, that brings a different challenge in terms of how do we have dementia-friendly properties, how do we get the homes to really train and think about their staff working with people with dementia, which offer a different range of challenges from what we saw 10, 15 years ago in care homes, where people would get up in the morning, have some breakfast, get in their car and go off for a day shopping and come home at the end of the day and need a bit of personal care. And these are real challenges for the system to think about. We know it's about also getting health and social care together. And if I really look at one of the things that I think has been done amazingly in East and North Herts, the work that's been done with the Herts Care Provider Alliance, the work that you've done to really bring together your care homes and to network them into a system is amazing. It's given huge benefits to them, but also a single way to have conversations with social care providers and care home providers to talk about what it is you want to do with them, to build services with them. And this morning in Newcastle, I was talking to them and they were saying about the challenges they're facing at the moment working with their care providers. And they're actually getting your team from here to go up to Newcastle to tell them how to do it. And it's only through being able to network in this programme we've been able to do that. Otherwise, Newcastle would potentially have been waiting 2-3 years to get to the point that you're at already, and you can cut them to get there much, much quicker. Similarly, it's about workforce, it's about having the right workforce. And in this part of the world, you know the real challenges you face from a vibrant retail sector, from your proximity to London. You've got to get the workforce trained and developed and supported to keep you there. And again, your complex care premium and the work you've done with developing and supporting your care home staff and getting primary care to really transfer skills to those care home staff to support them has been really, really powerful, and again is seen as a real best practice exemplar nationally. And then finally, another area where you really excel is in linking up your health and social care data, and how do you bring together information so you can really start to understand it. And some of the conversation we were having yesterday morning was about, so you've got this data, what are you going to do now to really give that to your clinicians to make a difference about clinical practice? Okay, it's great, we can sit in a room, we can have this really exciting conversation about whether this graph shows that or the other, which I do quite like, I should admit. But actually, the really exciting bit is what happens when I then give that to clinicians and then they can start to use it to really drive the clinical decision making that they have. It's really exciting stuff. So what are we doing this year so that it isn't just us that hears about this, and it isn't just the 6 places and the other 44 Vanguards? Well, the first thing we're doing is that we're working through the planning process through the STPs to really say to them, how do you learn from the care home Vanguards and places like East and North Herts to implement this model locally to really deliver benefits to your ageing population? Secondly, we are working with other Vanguards and Pioneers. We've had a huge amount of interest. So on my train down today, I was sending emails to people and having phone calls with people saying, oh, I should link you up with this person. So I sent an email today, somebody who's working down in Surrey, who's got a piece of work they're doing around their community hospital, who wants to be linked up with the work you've done looking at intermediate care beds. So I sent an email today saying, right, you really need to speak to these 2 people, because what they're doing in East and North Herts is completely applicable to what you're doing, and you might have something where you're a bit further on that they could learn from. And then finally, we think that there's a huge opportunity to work with the providers themselves. So there's lots of people who provide social care in this country. So how do we work with them to actually work out what they could do without having big system changes as well? Because there are parts of this care model you could just do tomorrow and transform some of the care we give. So some of the examples of how you're doing this. I won't go through all of these, but suffice to say, every single Vanguard in the care homes cohort has something slightly different to offer. What's interesting is how you've started to learn, adapt and adopt from each other. So where you're taking something such as a hospital transfer protocol, which is the red bag in Sutton, and thinking how that could apply for firstly people in care homes and then domiciliary care in East and North Herts. Or the work, as I said, that we've taken the idea of how you're working around the complex care framework and then taking the complex care premium and putting it into other areas as part of the training and development packages. There's huge amounts of opportunity for sharing, and this is something quite unusual that the NHS hasn't traditionally done very well. So I think there's lots of exciting things in there. So I'm going to stop there, and I suppose I'm just going to finish off by saying, why did I want to come here today? I wanted to come here today because I genuinely feel as exciting and as alive as I've felt in a job in the last decade. And that's a result of working with the work you're doing. I don't deliver anything, and pretty much every boss I've had for the last 10 years will tell you that. But by being able to come and work with people like yourself and to understand what you're doing and to be able to then go somewhere else and look at how could I take that and spread that to a wider population has genuinely been one of the most exciting things I've done, I think, at any point in my career, but certainly any point in the last 10 years, I would happily have given it up just to do this. And that's why I came down here today. And I think, as hard as it is out there, I think there are many, many amazing things you're doing locally. And find a way to celebrate that, because the stuff you're doing is exceptional. And I'm going to stop there.
Does anyone have any questions for William at this stage? Okay. Thank you. So next up, we're going to have a talk about primary care delegated commissioning. So Dr. Nikki Williams, who's co-chair of Upper Lee Valley and deputy chair, and Harper Brown, director of commissioning.
Right, we're going to do another... Sorry?